Hi. Well, obviously I was asked to talk on ankle fractures in special situations. Well, you ask any patient if they're special, they'll say, yes, I'm special. So every ankle fracture is a special situation. What I've tried to do here really is to break it down into maybe the difficult patient or the difficult bone. So I'm going to talk about these in sort of general terms. I'm going to start off really talking about the difficult patient, ones that have complicated diabetes. And there is evidence out there that if you've got an uncomplicated diabetic with good control, actually their risks of surgery are the same as anybody else's risks of surgery. So don't be afraid to operate on well-controlled diabetics, they do well. The ones that have problems are your complicated diabetics, and by complicated diabetics I mean they've got some degree of organ failure, whether it be renal impairment, whether it be cardiovascular or retinopathy, and they may have neuropathy as well, and that's the thing that we're all concerned about. There is evidence that union takes twice as long in diabetics, bone healing takes twice as long. There's no doubt that their infection rate is higher when you've got complicated diabetes, and it's up to 30% higher. The amputation rate is a lot higher. Amputation rate after a straightforward ankle fracture in a young patient is probably well less than 1 in 1,000, but in your complicated diabetics you're looking at a 4 or 5% chance of them losing their leg. And of course, non-compliance. There's evidence out there again that these patients have cognitive impairment. It's not because they're idiots or they don't listen to what you say. They've actually got problems from the high glucose. It affects their brain. So this is what we're all trying to avoid. Okay, this is your horribly infected post-surgical diabetic foot, and their toes are dropping off. So nobody wants to see that. So you want to try and make it as good as it can be in the first instance. I'm going to go through a few examples here. The first one is one that turned up in the multidisciplinary clinic. And these were the x-rays that I was presented with when the physicians came through scratching their heads saying, this guy's just got gross ankle swelling and gross foot swelling, and we can't explain why. We think it's cellulitis, and they've been treating him for a couple of weeks with antibiotics. He had no pain because he was neuropathic. He had a superficial ulcer under the third metatarsal head, but they were kind of scratching their head saying, what's wrong? If you look closely at the x-ray, there's a problem with the subtalar joint there. Now, this is why you need somebody who's quite experienced with diabetes. If you don't look for these problems, you won't find them. But I would say that you don't need to be an expert to recognize that there was gross swelling here and there was something going on. So I think it's an important clinical sign. If you've got unexplained swelling in a diabetic, that needs further investigation. Don't ignore it. When we got this guy's MRI scan done, you can see there's a dislocation of the subtalar joint. Okay? There's the talus, there's a fracture dislocation, there's the calcaneum. Okay? So, how was this treated? Well, this was treated elsewhere before I got to it. It was a couple of weeks down the line. They're always treated elsewhere when they go bad, aren't they? So anyway, it was treated conservatively, and they wrapped him up in a plaster. Now, why did they do that? Well, possibly because of infection rates, and they thought, well, you know, maybe I don't want to be operating on this. Because it was too difficult and there was a non-compliant patient? Or was it because there was Charcot and they thought, well, this is not an acute situation, so let's just run with it and see what happens? Problem is, he comes back 2 weeks later, and this is his x-ray 2 weeks later. Of course, his swelling's got worse, and now he's got a hugely unstable varus ankle. So he's treated in a backslide plaster. He wasn't educated. They didn't say, stay off this, don't walk on it. They just wrapped him up in a plaster and sent him home. So he came back with this, got severe unstable ankle deformity, and really the only thing you can do here is a salvage procedure. And I've stabilized him with a hindfoot nail, got the calcaneum back underneath the talus. Yes, it's not perfect, but it's a heck of a lot better than he had. Okay? But you don't want to be getting into this situation in the first instance if you can avoid it. So, I think in the acute situation, even if they are complicated diabetics, I think you've got to be doing something to them. Don't treat them any differently to how you would treat somebody else, just because they're diabetic and just because they're Charcot. But you've got to be aggressive with the fixation. But think long term. Deformity is likely to result in ulceration in a neuropathic foot. So if they've got deformity, try and get it corrected. And I think if they're non-compliant, you're going to get problems with further deformity and fracture. Just another example. Again, it's a diabetic. He's got early neuropathy. He's got patchy neuropathy. He's 150 kilograms. Didn't want to really go in there and operate on him, so what did they do? They wrapped him up in a plaster. Looks a reasonable reduction there, but where else would you treat a Weber C ankle fracture conservatively? Would anybody treat a Weber C ankle fracture conservatively? No, it's grossly unstable. What's going to happen? This is what happens, okay? Now, he actually had pain. So not all of your neuropathic patients will be pain-free. So in this instance, he's got obvious diastasis here, he's got obvious widening of the medial clear space, and he's got pain when he walks on it. Now, I think there's a good argument here for doing an ankle fusion, all right? I actually didn't, but the principle here is that you've got to use rigid, strong fixation. You can see what I've done here. This is a DCP plate. These are large fragment screws, and they are multiple syndesmotic screws here, or multiple tibiofibular screws here to actually keep it reduced. And I also fused the inferior tibiofibular joint. And he had a reasonable outcome at the end of the day. Okay? So I think if you're going to fix them well. Whatever you do with them, make sure it's a hardy implant and make sure you fix them in the anatomical position. And they need extensive stabilization. So it's got to be a stable construct, and you've got to take into account that they may walk on this. And don't assume that it'll be pain-free, because it may not be. Third situation, again, this is his x-ray initially. Why did they miss the problem? Because it wasn't a weight-bearing x-ray. All right, so make sure that you get weight-bearing x-rays, and here you can see there's a dislocation. This is one that I did. I did a fusion of the ternavicular joint and stabilized his medial ray. However, even I don't get it right, okay, because he progressed, and this is him a few months down the line, okay? What I should have done was put front to back screws in all the way along that ray, okay, and given him a really stable construct to stand on. So you can see that even if you do go in there, you've got to be aggressive with your fixation, or otherwise it'll come back to bite you. He's better off than he was, but he's not perfect. Okay, so don't ignore unexplained swelling, be aggressive with the internal fixation, and it has to take into account that they'll be non-compliant, and immobilize them for twice as long as usual. Okay, just going to talk about osteoporotic fractures now. It's a big problem. 1 in 3 women, 1 in 5 men will suffer an osteoporotic fracture in their lifetime. And achieving good fixation in soft bones is difficult. So what techniques have we got that are available? Some of these are very basic techniques, but this is a good technique, especially if you've got a lot of comminution of the medial malleolus. Tension band wire technique can be very, very good. It acts basically as an internal suture. You can do this on the lateral side to supplement your plate fixation. If you're putting your distal screws in and they're just twisting around, what you can actually do is slot a couple of K-wires up inside the fibula, and you can use that to actually hold your screws in. You screw your screws in through the K-wires, and it actually gives them extra purchase. I would caution you against using this in the pronation adduction injury where you've got a vertical fracture line. A tension band wire in that situation will cause it to displace. So be careful, it has to be a transverse fracture. Anti-glide plates, very good. Biomechanically, a lot stronger. So instead of plating on the lateral side of the fibula, you put the plate on the back of the fibula. And it's very much superior from a biomechanical point of view. You don't have to put distal fixation in, but I think most of us feel happier if we do. But it can be difficult to apply to the back of the fibula due to the shape. Okay. Cement augmentation, it's not something I do, but it is described where you can actually pre-drill your holes, position your plate, put it in proximally, and where you've got poor fixation distally, you can actually squirt a bit of cement in just using a syringe. Again, it's not a technique I use, but it is described, and it is said to give reasonable fixation. Don't insert your screw fully until the cement has gone off. Get it almost all the way in and then tighten it into the cement once the cement's gone off. But again, thermal necrosis and cement leakage is a potential problem here. It is available. I've not particularly used it, but it is described. Locking plates, well, they're sexy implants, aren't they? Yeah, and we all like playing about with new implants, but there's actually no clear evidence in the literature that they work. Okay, I find they're quite useful because a lot of them have got multiple distal fixation holes, and that's the advantage that I find to them, that they give you a much better option in the distal fibula there. Hindfoot nail, I use this quite a lot, especially in the diabetics. There is good evidence out there that in your low demand elderly patient, you can stabilize with a hindfoot nail, and then you can remove the nail after about 3 months. In fact, a lot of these patients are so happy that you've got their nail in there and they feel great, they don't want the nail out. And there is evidence that later on these nails can break, although they remain asymptomatic. What else is out there? Well, again, there are these new sexy implants. Here's a fibular nail, and you can actually stabilize the syndesmosis through the fibular nails also. I've not got a lot of experience with using these. This is one of Jit's cases, so hands up there, Jit. But there's questions about, can you control the length and can you control the rotation? But it does give similar results to open reduction and internal fixation in your low demand osteoporotic fractures. So these are all techniques and implants that are out there that we can use with osteoporotic bone. So it is an increasing problem. There are some simple techniques that are easy to do that you're all familiar with. There are newer techniques, but we really don't know what the best form of fixation is. And really, prevention is your best medicine. All right? Treatment of the osteoporosis, aggressive treatment of the osteoporosis, doesn't get you into this situation in the first place. Okay. And the one that you will hear time and time again is the diabetic. I think that there's two classes of diabetics. There's the well-controlled diabetic who